I'm Bob Spiritus. I try to coordinate this, and our president, Bob Hopper, is the power back there. He's our president. Today we have a wonderful presentation by two very highly educated and wonderful people. They're going to present. Dr. Macklis, Roger Macklis will present first, and Dr. Wendy Shaw will then come in as a second speaker. Dr. Roger Macklis is a professor emeritus in radiation oncology at Case Western University. He graduated summa cum laude from Yale with a BS and MS in molecular biophysics and biochemistry, and then got his MD with honors from Harvard. That's a nearby school. After training in radiology and radiation oncology at several of the Harvard hospitals and Dana-Farber, he joined the faculty of Harvard Medical School. His primary clinical and research interests were the development of new technologies and radioimmune approaches to the management of lymphoma, breast cancer, and metastatic disease. In 1993, he was recruited to chair the newly formulated Department of Radiation Oncology at the Cleveland Clinic, and from 1993 to 2023, he pursued a career in academic oncology, including clinical research and administrative practices, was the author of over 200 full-length articles and several books. He retired at the end of 2023, but maintains an active consulting practice. He and his family have been coming to Chautauqua since 1995, and they maintain and utilize a vacation property on the grounds of Chautauqua Institute. I'm going to introduce Dr. Shaw also right at this point so that we can just go through all the slides quickly. Dr. Shaw is also quite accomplished. She graduated Phi Beta Kappa magna cum laude with highest honors in biochemistry from Smith College and was part of Sigma Xi Honor Society. She had a teaching assistantship at Smith College and a research grant from the American Heart Institute. She is board certified in diagnostic radiology, belongs to several medical societies, and interned in the Department of Medicine at New York Hospital, Cornell Medical College, did a residency at the same place, and did a fellowship in CT ultrasound at Thomas Jefferson University in Philadelphia. Yeah. Her appointments, professional appointments, she's on the section of breast imaging in the Department of Diagnostic Radiology at the Cleveland Clinic, and a senior clinical instructor in the Department of Radiology at Case Western Reserve. She and her husband, Richard Spivak, have been coming to Chautauqua for 33 years, and they own a property here in Chautauqua. So please welcome our two speakers, and we'll let Dr. Macklis start, and he will be followed then by Dr. Shaw.
Good morning, and thank you so much for joining us on this Week 2 Science Circle set of presentations. And Wendy and I thought that because this is the AI week, we will apply AI to one of the areas of our interest, which is breast cancer. So this is going to be a two-part talk. I'm going to do sort of the background of AI as a role in cancer medicine. And then Wendy will pick it up with specifics about things like mammography. So next slide.
If you move around, Dr. Macklis prefers to speak from that position. Just move around. There's plenty of room here. Move around so you can see him. So you can see the slides.
Okay, ChatGPT. I think for many of us who don't think very much about things like AI, the first time we ever really spent much time thinking about it was probably November of 2022, when the San Francisco-based company OpenAI produced and allowed free access to the first famous large language model available, which was ChatGPT. Next slide. So even though those of us who don't know very much about it thought that this was very new, in fact, the area of artificial intelligence goes back a while to the early decades of the 1900s. And the person who put together this timeline says actually in the 30s and 40s, people were already talking about AI, But I think for many of us, a signal event happened in 1950. In 1950, Alan Turing produced a paper entitled "Can Machines Think?" Now, you probably all remember Alan Turing, the brilliant polymath, British polymath, supposedly had an IQ of 185, and he's the one who solved the Enigma code during World War II, probably saving tens of thousands of Allied soldiers. But he was the first one to seriously start thinking about, can machines think, and what does it mean for a machine to think? Do all machines think? Well, I think for most of us, a 4-function calculator, we wouldn't say it thinks, it's just a function machine. You put a digit in, and it gives you a response. But I think as machines got more and more sophisticated, they came closer and closer to what we think of as thinking. And certainly, there was a lot of interest on the part of government places like DARPA at places like MIT. So they began seriously evaluating the whole role of AI until another signal event occurred. In 1997, Deep Blue, a computer program from IBM, defeated the international chess champion, Garry Kasparov. That was 1997. Many people thought this is not going to happen, at least not in this century, but it happened in 1997. Deep Blue beat a human. Next slide. Now, for Wendy and for me, we're physicians, so if you ask the question, what do you see as the most important use cases for AI in your organization? Well, for doctors like Wendy and me, the first major area for AI was really fairly plebeian things like physician coding and record keeping, administrative automation. Those are the big numbers. But a little bit farther down the list, research into new conditions or disease states. This is about 30% of the responses. And this is where I think most physicians are hoping AI will really shine. Next slide. And if we say, what branches of medicine are being impacted by AI? And the answer is, at this point, almost all of them. So cardiovascular health, cancer care, dementia, but a big piece of the pie, and the one that we're going to focus on today, evaluating diagnostic results and imaging. That was something like almost half of the responses. Next slide. Breast cancer. Breast cancer, as we all know, is a very important disease in the United States. Something like 1 in 8 women will develop breast cancer in their lifetime. And so, of course, we all know that if you want to cure a cancer, it's almost independent of what kind of cancer, it's best to treat it early, to find it when it's at the earliest stage. And certainly, mammography was one very important early way to diagnose breast cancer. And you see, even the old days of 2D mammography, you can already see quite a bit. We can see the surface anatomy, we can see the contours of the breast tissue, we can see the vasculature, we can see the nipple areolar complex. So even at a 2D mammogram, we already can see quite a bit. And you can imagine that there was a funny conjunction of soft tissue changes there. You may be able to see them. But this is the old days of 2D mammography. Now, I think most places are doing 3D mammography, meaning you're able to reconstruct the breast tissue essentially in all dimensions. And this is something which has really made us much more comfortable saying that we are likely to pick out almost all the important cancers. But, I said almost, it's something like 90% of cancers are found on mammography. There's about a 10% false negative rate and a 10% false positive rate. People who look like they have a cancer and require a biopsy, which ultimately doesn't show it. So mammography, even 3D mammography, is good, but it could be better. And that's where AI comes in, and Wendy will tell us much more about that. Next slide. Barriers to AI adoption. Many people think, why was medicine so late to the party? Why did almost every other field automate and digitize? Decades before it became the standard of medicine, decades before we had widespread electronic medical records. I think to some degree we can blame it on the fact that doctors are traditional and it takes them a while to get into new technology. There's also HIPAA issues, meaning as soon as you put everything online, then you become liable to a HIPAA intrusion. But a survey said having staff and experts trained in utilizing AI was the top barrier. So we needed to build the capacity of people who were fluent enough to actually make use of the technology. Next slide. So I think in the current era, we're thinking about really utilizing AI, but even though we say it stands for artificial intelligence, I think for many people who use it, we would like to think of it as augmented intelligence. So it's not a replacement for physicians. Most patients who go to the doctor say they don't want to spend their time staring at the back of a doctor who's looking at a screen. They want to actually have face-to-face contact with the doctor, and they want the doctor to use the technology sort of in the background. So augmented intelligence. Next slide. So AI is starting to revolutionize the sorts of tasks that doctors previously performed based only on expert training and recall. Now, expert training and recall are actually very good. We get a lot through that. But once you have the system like three-dimensional mammography, where we can look at, instead of one 2D mammogram, if we look at 100 or more mammograms, and then we have to go back and compare them to the patient's prior mammogram, you see that we actually have to be able to understand the change in, it could be thousands of images, thousands, and that becomes almost impossible for a single physician to do, and that's where AI comes in. Next slide. Now, I'm a radiation oncologist, so I spend my professional lifetime aiming high-energy beams at tumors anywhere in the body. And this is an example of a set of CT images. Now, CT, three-dimensional imaging, that dates back to, let's say, the early 1970s. And by the time I was in training in the early 80s, I remember sitting there with the attending, going through all the panels of CT images and trying to just outline all the normal tissues. So we could see the liver, we could see the spleen, we can see the kidneys and so forth. We can see the bones. We can look at the bones and we can say, well, gee, does everything look normal there? And you say, well, these all look pretty okay. But then there's something here. What is that? Something that requires further evaluation. And you say, well, let's look at what are the nearby normal structures. So we go back, well, here's the brain stem. And these are all things that a human can pick these out. And I remember sitting with residents and outlining with grease pen. Wendy, remember the days of grease pens? With grease pen on hard copy. Say, well, all right, here's the brain stem. Now, if we feed the CT images into the AI system, it automatically identifies the normal tissues. It outlines them, it names them, and it tells us, is there anything here that does not look like it should be there? Next slide. Same thing for pathology, breast pathology. Pathologists, when we go to tumor boards, they present sort of their summary of the cases, and they have spent perhaps hours looking at an individual case, looking at normal breast tissue, looking at cancerous breast tissue, and identifying what kind of breast cancer is there. Is it high-grade breast cancer? Is it triple-negative breast cancer? Is it low-grade cancer like DCIS? So the pathologist used to have to identify everything and say, all right, what % of the total specimen represents DCIS as opposed to invasive cancer. And if we look at lymph node metastases, is there any evidence of tumor in the lymph nodes, or is it normal lymph node tissue? And then, of course, the pathologist has to issue a report. Now, in the old days, it would take a long time for them to actually come out with all the information and write their report. Nowadays, if you feed the breast information, the pathology, into an AI module, it actually will outline everything, name everything, tell you what is sort of normal versus not normal, and what kinds of breast cancer are clearly visible, and it will write a report for you. Now, interestingly, in the United States, it is still considered inappropriate to say that the report that comes out of the system is the final report. In the United States, a human, a pathologist, needs to actually review that, look at the slides, and say, yes, I agree with what the machine said. Interestingly, in Europe, that's no longer true. In Europe, there are many places where the final feed out on pathology is what the AI system gives you. A human doesn't really need to be in the system. Next slide. All right, so we are now in the era of augmented intelligence, especially for things like mammography. And if you say, well, gee, does that mean we really don't need radiologists anymore? Can we just rely on the machines? And I think what most of us now believe is it's not a matter of the doctors being replaced by machine, but the doctors without machines are being replaced by doctors with machines. And Dr. Shaw is one of the experts, and she'll pick it up from there. So, Wendy.
Thank you. You want to do your own slides?
Yeah.
Okay,
Thank you.
just push the first button.
Got it.
Get it out of the way.
Good morning, everybody. So I work at the Cleveland Clinic, which is a very big healthcare system. We have 17 breast radiologists, and we read 120,000 mammograms a year. So we're very busy, we're very high volume. And one of the things that has come to pass is it used to be in the old days when you got a mammogram, you got 2 films of each breast. But now something has come along. We've been using it since 2016. It's called digital breast tomosynthesis, DBT, or 3D imaging. And what that means is instead of just taking 2 views of each breast, you're taking slices through the breast. So you're adding hundreds of images to what the radiologist has to read. So it's really improved our diagnosis, but it's made it harder for us to do our job. 3D imaging has been around since 2011, and now I would say about 82% of breast centers in the country use it. And it's shown to be very advantageous. There's increased cancer detection, decreased recall rates. Recall means that we tend to batch read screening mammograms. So a woman comes in, gets her mammogram, and leaves. That's a screening mammogram. And then we batch read them, and we either pass you or we recall you. And for those of you who've been recalled, it's extremely stressful to know you're getting a call back. And most of the callbacks are benign. But anyway, so that's what recall rates are decreased with tomosynthesis, and there are decreased false positives. So what are the challenges of using DBT, digital tomosynthesis? Well, there are hundreds of images versus the normal 4, and it doubles the reading time for the mammographer because instead of just looking at 4 films, you're looking at hundreds. And it just increases the amount of time it takes to read a mammogram. There's increased radiologist stress and fatigue, and there's still unnecessary callbacks and false positives. And as someone said, reading a mammogram is like finding a snowball in a snowstorm. So burnout is a big problem in medicine these days, and I think anyone who's interfaced with the healthcare system in the United States, and especially in Canada, knows that there are a lot of radiologists and a lot of doctors who are retiring. They're just burnt out, volumes have increased. So why is there burnout in radiologists? Well, there's a global radiologist shortage. We could hire 5 to 10 more breast radiologists to cover the work that we do. There are increasing demands on our attention. There's pressure to see more patients in less time. We also have learning requirements. We have residents, we have medical students, so we have to do teaching. And they've also opened the floodgates for screening. I mean, now everyone, over 40, every woman over 40 is supposed to get a mammogram. So what about AI? Well, we've been using AI I've been using it for over 10 years. And it really is a remarkable thing. It's proven in a large reader study to improve radiology accuracy and efficiency. There's an 8%, on one study, there's an 8% increase in sensitivity, there's a 7% reduction in recall rate, and there's a 52% reduction in reading time. So what's the advantage of AI? Well, one of the advantages is there's less variability between radiologists. One of the things we used to do is have 2 people read a mammogram. Well, now with the shortage of breast radiologists, I don't think that happens in many places, but there's less variability when AI is used. There's increased sensitivity with AI, there's increased specificity, and there's improved reading time. And that's the big thing, the improved reading time. When tomosynthesis came, it improved accuracy by about 4%, but productivity was down because it doubled the reading time. With AI, accuracy improved by 5.7% in one study, and productivity increased, which meant that the radiologists could read the tomosynthesis study in the same amount of time that they used to read the 2D study. As you're going through images, multiple images for each view. Now, how does AI work? Well, when I'm reading a mammogram, it's all digital. I have the mammogram up, and I press a button. And what that button does is there's an algorithm that has been developed by the AI company. This company is called Profound AI. That's just a trade name. And what it does is if it sees a lesion, it will circle it. If it sees a calcification that's abnormal, it will put a square on it. And it's calibrated from 1 to 100%. And it refers to a database of similar findings. So it'll give you a score for a lesion, and it'll give you a case score. The case score refers to the database with tissue of similar appearance, and it represents the algorithm's confidence that it contains a suspicious finding. So here, this lesion, so this lesion here with an asymmetry, it was given a 97%. And this lesion here was given a 48%. And so there were 2 findings, and the case score was 99%, which meant it was very, very suspicious. Oh, I'm sorry. So the top lesion was given a 97%, and the bottom lesion was given a 45%, and the total score was 2 lesions, a case score of 99%, which is very, very high. So before I show you a case, I also want to say that AI is not infallible. Like, one of the things we see on mammograms that is not breast cancer is we see calcification in arteries. Arterial calcification, you could see it on a foot film, you can see it on any soft tissue films, and it's a benign finding. And AI often puts a square there. So the I don't want it to seem like it's infallible. It'll mark things that are not anything. So you've got to be able to filter out the noise, that background noise. So here's a case of a 47-year-old patient who presents for her final 2-year follow-up of a finding in the right breast. But incidentally, a subtle finding was identified in the left breast. So this mammogram, this is a 2D mammogram, meaning that there were 2 views of each breast, and this was negative. However, if you look at the films, there is a finding. There's one view, it's called a craniocaudate view from 2020, then there's a view from 2022, and then there's a view from 2023. And if you look at 2023, there's very subtle asymmetry here. It almost looks like it has, it's what we call spiculated, like it has the starburst appearance. And this area was seen and it was biopsied, and there's now a clip. You can see a circle and there's a little clip there. And this was invasive ductal carcinoma. And this was picked up by AI, by using AI. But I mean, hopefully if you're good at this, you would have seen it also. So, but sometimes, you know, you do need the AI. So it helped in this case to find a small, subtle, invasive cancer at its earliest possible stage and in a younger patient. Here's another case of a 77-year-old woman with a history of a previous mastectomy, and she was recently treated for left breast cancer that was initially detected on routine screening. So here's her mammogram. The clips are because she had a lumpectomy and she also had radiation therapy. And this is a 2D mammogram, and it's negative. And this was in 2023, after her surgery. So let's go back to 2022. Well, in 2022, there were no suspicious findings on the 2D images. It was interpreted as negative, and tomosynthesis was also performed. And there's an arrow pointing to a very, very subtle asymmetry in the lower outer quadrant of the left breast. And this was picked up by tomosynthesis. It was a fairly subtle mass, and it was made more conspicuous because it was circled. It's identified in both views. And there's a percentage. The image, one of the images, the lesion score was given 42%. On the other view, it was given a 47%, and the case score was given as 66%. So this helps the radiologist read the film. But again, AI, it does pick up things that are nothing, and it also overreads. And it also misses things. If you look back at 2021, this is the radiologist's worst nightmare, the screening exam was read as negative, but the tomosynthesis, in retrospect, picked up this small asymmetry. So this was a missed cancer in 2021. Again, lesion score 51%, case score 70%. And this was biopsied. You can see there's like a circular metallic clip there. So what are the learning points for this? Well, small and subtle invasive cancers are very difficult to detect. And it was very difficult to detect it in 2022. The screening exam was negative in 2021, but in retrospect, the cancer was seen on tomosynthesis, and AI identified it in 2021. So this is an outside case that I mean, radiologists do miss things, but the fact that AI picked it up, the radiologist should have looked at it twice. So many people say, are radiologists going to be replaced by AI? Well, for one thing, the breast radiologists at the clinic, we do a gazillion biopsies, so I don't think, maybe eventually a robot will be able to do it, but we do all these biopsies. But I think the best way to look at this is that AI is helping us detect small and subtle cancers. It reduces satisfaction of search, and that's a phrase that we use in mammography, where you're reading a mammogram and you see a cancer in the right breast. Satisfaction of search means you think, oh, there's the cancer, I'm going to write my report, right breast cancer, left breast negative. Well, that's satisfaction of search, because just because you found the cancer doesn't mean there isn't anything in the same breast or the other breast. So AI helps reduce satisfaction of search. It helps reduce human error because there's no one who hasn't missed a breast cancer. I went to a meeting years ago where a very famous mammographer was giving a lecture, and she showed a mammogram, and there was a breast cancer there. So the first thing most breast radiologists do when they see a cancer that's, suspicious is they go back to the year before to see if it was there. And I remember her lecture because she said, and you go back to the year before, and then they show the image, and her next slide said, and it was there. And so you look to see who read it, and the next slide said, and it was you. So, I mean, we read a gazillion mammograms, but everybody does miss things, and in retrospect, you can see things. So AI helps with human error and missed cancers. And the other thing that it can be used for is it gives a scientific breast density assessment. Now, a lot of people have heard about breast density, women with dense breasts. There's now a law where, and I know this is in Ohio now, where you give a woman her mammogram report. If she has dense breasts, you have to tell her. The reason being that if you have dense breasts, it's harder to read the mammogram, you may miss things, and there are supplemental things that we now do for women with dense breasts. We do automated breast ultrasound, we do MRI, so what AI does is give a more scientific assessment of the density of the breast. So is AI going to replace radiologists? Who knows? Right now, no. And as one doctor at Stanford said, AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't. Thank you.
Okay, this is your chance to come up and ask a question. While you're doing that, I'll advertise next week. Dr. Terry Gordon's going to talk about the health effects of vaping. So please come back the same time, same station next week. Please come and form a line, ask a question. I guess we'd like to have our speakers here to answer it from here. So you guys are on the spot. I'm not going to answer your questions. So. Yeah.
Hi there. I was surprised by the statistic that said it only improves accuracy like 5.6% or something like that. I would expect it to be so much better than that. Maybe it'll get better than that. And then also, what about the cost? Does it really reduce the cost of detection?
It used to be that we charged for it, but now we don't charge for it, so it hasn't increased the cost. Maybe the accuracy hasn't increased as much as you think because the radiologist reading it is better than you think. It could be. Maybe general radiologists reading mammography, it would be a higher percentage, but a breast radiologist who does it all the time, not that they can't miss things, maybe that's why.
What about your time per case?
Time per case is down, yeah, absolutely. It gives you, it just makes you feel better. It's, you don't rely on it, especially because it picks up a lot of benign things, like, as I said, vascular calcification, which can mean something medically, but as far as breast cancer, it means nothing. So, yeah.
I'm curious about the mechanism for this model to continue to learn, whether that's through expert feedback from physicians who could suggest corrections based on trends they see, or by growing the size of the model through recontributing data that you acquire in this way. Related to that, in your personal experience over 10 years or whatever, have you seen improvements and learning in the model?
I haven't seen that much improvement, but I don't know why. I would imagine that, you know, if we got new software, that it would just, oh, I'm sorry. I haven't seen that much improvement, but that may be because we haven't updated our software enough. But I would think that it would improve because the more data, the more that you amass, the better, you know, your accuracy will be.
Do all of your films go into?
I thought he was asking the same thing. Do all of your films automatically go back to the AI company that does this?
Yeah.
Well, Wendy, I remember maybe a decade ago, only 1 or 2 Cleveland Clinic centers had 3D mammography,
Right.
and now all of them do, right?
All of them, yeah.
So I'm interested in how this machine and humans, you know, work together. So this is augmentive. So let's focus on the errors, when missed cases. If it cuts the radiologist's reading time down so much, then the radiologist, by definition, is not independently reading the X-ray, the mammograms. And so I'm wondering if the human is just focusing on what the AI is pointing towards, and you're not reading the other part, and maybe that's where the missed cases are, and how that's going to sort out over time.
You click a button. Oh, I'm sorry. You click a button. So I read it, I decide what I think, then I click the button, and it shows me what AI found.
Well, if you're reading it independently, why is your reading time going down? It would seem like if you're reading it in the same way you were reading it.
I see what you're saying.
Yeah.
Let me think about how to answer that. Maybe because it makes you more secure to read a little faster knowing that AI will. So you feel more secure going a little faster.
So it's paranoia time.
It's
decreased.
paranoia.
Okay, that's helpful. Thank you.
Do you have any experience or information about the use of AI in detecting cancerous cells that haven't proliferated to the state where they're forming tumors yet?
You know, this is obviously an area of active research. It's not something that I or Wendy have any specific information about. You need another science talk for next year. I mean, this was only sort of one little part of cancer medicine. But I remember reading something about the physician who wrote a very good history of cancer medicine. I think it's called The Emperor of All Maladies. He is Siddhartha Mukherjee. He is actually a medical oncologist in New York City. And his area of use of AI in medical oncology is he wants to track the impact of different diets on how rapidly cancers grow. And of course, that's something that would be absolutely impossible to do unless you have a system like AI, where actually you can feed all the information into it. And that's one of his big research interests now. But these are all things that are being evaluated.
The Emperor of All...
The Emperor of All Maladies.
All Maladies, that's
a wonderful, wonderful book.
That's for me. Thank you, Doctor.
I'm a retired internal medicine physician, and I remember being in the 60s when my husband was at MIT, and one of his colleagues, an electrical engineer, went to work for Hewlett-Packard. His first job was to figure out how a machine could, or a computer could read EKGs. And now, of course, EKG reading is done on almost all the machines when I went into practice in the 80s. what I wondered is, you talk about like being at major centers, but in the local communities, we're just starting to get the 3D mammograms. And this basically argues for women to go for just regular testing to a major center where, I mean, we only have like 4 radiologists who rotate through reading mammograms and doing the biopsies, but we don't have, you know, the volume that other places have. And I wondered, you know, how this is going to work.
Well, eventually, hopefully, eventually, hopefully, it will go to 100% of the country. But I guess
if the health systems have that money and are willing to invest it,
right.
that's the problem.
Right.
And most of our health systems right now are cutting back
Right.
and not even doing,
Right.
you know, basic things.
Maybe eventually it will be mandated. I don't know.
Wendy, at a time before the Cleveland Clinic was doing tomosynthesis at every site, did you see patients change from getting their mammogram in the community where they didn't have it to the main campus? Or
Yes, people would call up and say, do you have tomosynthesis? Because like the University Hospital Health System got their first tomosynthesis machines before we did, which was a travesty. So, yeah, there were patients who would call up and say, I only want to go where there's tomosynthesis.
I've been a nurse practitioner in adult medicine for a long time, and this was already touched on, but I am from the end of interacting with patients who have found abnormalities that are not immediately worrisome. And it's especially with breast cancer and calcifications and repeated biopsies and every 3 months. And I would hope that that is just a major emphasis as well, is what should we not need to chase? But there's an awful lot of chasing right now, an incidental finding on a chest CT and repeat.
Right.
And it's very stressful. So if there can be some advancement in, does this mean anything? Yes, it's out of the ordinary, but does it mean anything as far as potential for cancer that's going to be problematic?
Well, I hear what you're saying because, I hear what you're saying because we cause a lot of biopsies. We cause a lot of benign biopsies. And I think with tomosynthesis, when we first started doing it, we really caused a lot of benign biopsies. So what's evolving, and I see it already, is how we react to what we biopsy. For example, intraductal papilloma is a kind of mass, and we can see it, we can biopsy it, and it used to be you take them all out, no matter what. Now the literature is saying just take out the ones that have atypical cells associated with them. Don't take out the ones, meaning that we biopsy it, and then if it comes back intraductal papilloma, we would send you to a surgeon, and the surgeon would surgically remove the whole thing, not just sample it the way we do. So now they're saying only take it out if there's atypia associated with it. So yes, we are picking up more things with tomosynthesis, but the pathology literature and seeing how these patients do is affecting how we treat them.
In New York State, a dear friend of ours was undergoing a cancer trial cure, had been doing it for about 6 months, was making progress, and then died suddenly at the breakfast table of a heart attack. We, the family and friends, requested that an autopsy be done. The doctors who had created the trial were not interested in doing an autopsy. New York State was not interested in doing an autopsy because it was not a suspicious death. The insurance company said they would allow an autopsy if the family paid $16,000. Will AI make it possible for our country once again to do more autopsies?
I think that's above our pay grade.
Can you help us try to make that happen?
It's not our area, but is there anyone here who has a comment on that? Come up to the mic.
I've been a nurse for over 50 years, and I was a nursing student, and everybody got to see their autopsy. You followed your patient, they died, and they were so common, they were routine. And that is not the case, because there's so much imaging, and that the conclusion is much more readily available of why somebody died, so it's less likely. So it's who's going to pay for that autopsy, because they're pretty arduous. If you're going to do it, it's pretty involved, and so I am surprised. And now I'm in outpatient care, and if a death is not suspicious in a private home, there won't be an autopsy because the backlog. We all know that when they're trying to find cause of death and medical examiners, the backlogs are ridiculous. So it's not an area that I have just seen that decline, and it's a matter of the imaging has answered questions enough that it's not routine anymore. And it can be very problematic. My boss is only 43, and she died in her sleep, and we'd love to know why that happened. But it was, she had just taken a plane trip like 3 or 4 days before from Europe, and they were assuming that she had a pulmonary embolism. And it's a lot of money to pay for it, but that's just a trend that has occurred in my observation over my career.
But medical science used to learn from autopsies.
Right, and the emphasis has changed, is where their learning is coming from.
What does a standard autopsy cost nowadays? Ballpark?
Well, it's thousands. I mean, you have to do slice by slice biopsies, and then look at those under and analyze all that tissue. It's a pretty. Wow, it's not even.
Thanks. I'm a philosopher, and I do research on AI with regard to.
Closer to the mic.
I'm sorry. I was hearing the echo from the walls, but not from the mic. Thank you. I'm a philosopher. I do research on ethics and epistemology, metaphysics, with regard to AI. And one of the things that I'm wondering about is sort of in terms of the way cancer cells are identified, right? In the slides, the impression I had was that typically it's focusing in on the specific spot and looking at its structure, color, characteristics, and so on. But at least in the way that AI often does pattern recognition in other contexts, it uses not only the text of the specific locale, but the context. So if you ask it to identify boats or people or cats or dogs or whatever in landscape scenes, it will pick up on whether or not it's outdoors, whether or not it's on the grass, and so on. And that will give it a clue as to whether it's a dog or a statue or what have you. And I'm wondering to what extent you suspect that AI, when it's picking up subtle, early examples, that it's using not just more refined analysis of the little patch where the cells actually are that are suspicious, but also that it's in some way using context of structural things or amount of calcification, whatever it might be. And also to what extent doctors are using that, whether explicitly or tacitly in the way that they make judgments about things. And what that might suggest about the future of using AI by adding more context.
Well, in terms of global, in terms of global, it does tell you about the density, the overall density of the breast, which I personally don't find helpful because if I'm looking at a gazillion mammograms, I know when I'm looking at a dense breast or I'm looking at a fatty breast. But yes, it tells you about the snowballs in the snowstorm, but it also tells you how bad the snowstorm is. And then if it is dense, then that can lead you to other imaging modalities, like MRI and automated breast ultrasound. So,
But in a larger context, though, your question is interesting because it says, well, can you identify with a reasonable degree of probability the likelihood of a breast cancer simply by the surrounding entirely normal tissue that gives you the context? And the answer is yes, that is certainly in use.
A little bit like if you're trying to identify a snowball in a snowstorm, you might, if you're looking under a tree or at the bottom of an avalanche or on top of a hill, a particular shape might be read differently, right? And yeah. Okay. Thanks.
Hi, good morning. I'm thrilled that you feel that AI has made a contribution to the study of breast cancer. That's wonderful. But as somebody who has had endless mammographies, for me, it would be better served to see if we can find a safer, less painful way to make these screens. All of us would appreciate that.
and it varies too. I mean, when I get my mammogram, it doesn't hurt at all. But there are women, and it's not because it has anything to do with my pain tolerance. It has to do with my breast composition, and women with really dense breasts find it painful. So that's the way it is right now.
So, okay, it was mentioned, I think it said 1 in 8 women will probably have breast cancer. Is this system of AI being used in other cancers, let's say prostate cancer, which is a higher percentage for men than 1 in 8 in women? Are we starting to use this in other things now?
Yeah, there are analogous studies sort of for every cancer that we have. So this was just an example using breast cancer. But yes, essentially everywhere on the playing field.
Just to end up with one other thing, do you think PAs will start becoming readers because you don't have enough radiologists? Because we're finding them in every field now, in orthopedics and dermatology, et cetera. Do you think that's going to happen, where you're going to have PAs being trained to read instead of radiologists all the time?
I personally think in the United States, there's still a lot of interest in medical students. As somebody with one of our sons just finished his residency, a lot of interest in going into radiology. Do you have any trouble attracting people?
Thank you.
There's a big shortage of radiologists in all areas right now. I think in COVID, a lot of them retired. I did. And then after a year, I decided I didn't want to risk bringing COVID home to my family, so I stayed home for a year with my husband. And then a year later, they asked me to come back and help out, and I've been working for over 3 years now. So, but a lot of radiologists retired. And a lot of younger doctors, it's a different generation. They want a better lifestyle, which I think is commendable. They want more time for their families, so maybe they're not working all the hours the older radiologists used to work, and they don't put up with a lot of what the older radiologists put up with.
They want to spend more time coming to places like Chautauqua.
Yeah.
Has AI had any effect on your department's malpractice risk and incidents? Good or bad?
When did you?
You know what? I don't know. Because it's interesting. When someone has, apparently the #1 malpractice lawsuit in the country used to be obstetricians, and now it's breast cancers. People don't talk about it. So like I found out a year later that one of my colleagues had been sued, but I didn't even know about it. So.
Your department must keep records, though.
Oh, of course they do, yeah. Yeah. So you know what, I would think that there would be less.
Is it saving money for the hospital?
Is it saving money? I don't know.
Yeah. Okay,
I really don't.
So my question is about what you think is driving the rate of adoption of AI, not only in your field, but perhaps others. It suggests when you have a 5 to 7% increase in sensitivity from the test, but you also have a 50% productivity increase. It suggests, as always in healthcare, the answer is money rather than quality. Okay. Is that going to be why we have to wait in other specialties so far for so long until it's produced a cost-effective finding rather than an improvement in the actual care?
Well, I mean, I feel like in medicine now, everything boils down to money.
Yeah, okay.
And that if they have AI and if you find more cancers, you're going to generate more money for the healthcare system if they're treated in your healthcare system.
Yeah.
So I would think that it would make more money.
I think, though, as Dr. Shaw was saying before, I mean, it's very, very interesting that patients are sophisticated enough to say, look, I now know that there is a new technology that can be used. I'm somebody with a family history, and therefore, by God, I want to go to a place that has the latest technology. So ultimately, every place is going to have the latest technology just for competitive reasons.
Thank you.
With so many women with breast implants, does it help you at all, or does it read just as well? With AI as...
With AI, yeah. I don't think it makes any difference. Breast implants, there is some tissue that is obscured with breast implants. It also depends if they're behind the muscle, in front of the muscle.
In talking to DSIC, it sounds like to be safe, that radiologists are more likely to send someone, even with something small DSIC, to go ahead and do the biopsy and proceed. And then the recommendation is often seems to be radiation. And my question is anybody looking at the fact that, I mean, we all know radiation, you can get too much of it, and none of us know when you've got too much of it. Is anybody looking at that issue?
Well, what I would say is, first of all, just because you see a small abnormality in the breast is certainly not an indication for radiation, not an indication for radiation. Indication for radiation would require pathologic evidence that it is a significant change. If there's just a change that's seen, it may be entirely unrelated. So I think that the percentage of breast cases in which we are actually using radiation is significantly going down, in part because we're able to give radiation a little bit more precisely, so we can give used to be like 6 weeks, 7 weeks of treatment. Now it's more like 3 weeks, 4 weeks, or less. So we're getting more focused in on those areas. But nobody, we tell the residents, no treat without meat. So we don't treat people who do not have a pathology showing cancer.
Okay, thank you very much.
Hello, I'm a radiation oncologist also, and thank you both for your really informative talks. One question I had was I was wondering if there are so among the lesions that AI has been picking up that were previously missed, have there been any trends as to the kinds of lesions those turn out to be? For example, invasive lobular carcinoma or any particular kinds of histologies?
I think just because of volume, it's going to be mostly invasive ductal carcinomas. It's mostly what it's going to pick up.
I see.
Yeah,
okay.
but from a pure volume, just because that's the most common.
Sure.
Thank you both for making this opaque subject a little more transparent. I want to say, some of you may not know the role that Chautauqua has historically had in topics like this and in developing scientific breakthroughs. Our polymath, Thomas Edison, who would dine at his table at the Athenaeum, at the time he was coming here, Edison was developing X-ray technology. Most people don't know that, but if you look, so we were involved tangentially and peripherally in changes in X-ray technology. And the number of things that Chautauqua has helped to encourage, and I hope that some of you here today have been encouraged to do more science, help your grandchildren do more science, and that you'll drop a 20 in the basket on the way out to help us do more science. And we're so glad you're here today, and we look forward to seeing you next week. And we are on Zoom. We think we got it working today, so if you're home and you want to keep watching, you can do it through Zoom. Also, we will post the talks. Sometimes it takes a couple of weeks, but you can go back and you can actually get a closer look at the charts if you were sitting in the back. So this is an ongoing process. It's part of science. Thank you. Yeah.